I'm going to be talking a little bit about what we do in our practice. I work for Pediatrics Medical Group, and I'm affiliated with Plantation Hospital. And I mainly do both pediatric and fetal cardiology. And everybody's probably wondering, like, fetal cardiology? So I'm going to explain a little bit what we do in our practice in our office. First of all, I want to explain to you what a pediatric cardiologist is. A pediatric cardiologist is a specialist that after doing training in medical school and pediatrics does a subspecialty in cardiology. And we basically take care of children all the way from the time they're born until the time they turn 18. A lot of the times we extend our age to adulthood because any patient that is born with a heart defect, we tend to usually keep and take care of them in conjunction with the adult cardiologist. We address diseases and irregularities of the heart in children, like I said, under 18, but we can extend if they're born with congenital heart disease. And we are also able to diagnose and treat kids or babies when they're inside mom, when they're in the womb, and I'll explain a little bit of what that means. We also take care of children who have acquired diseases. Not only they're born with heart problems, but they acquire heart problems through their lifetime, and we also take care of those kids. As I mentioned before, we also take care of kids when they're inside the womb. That's another, I wouldn't call it a special field, but some of us decide to do some special training during our fellowship where we take care of patients when they're inside the womb. That's a field called fetal cardiology. And what we basically do is we do ultrasounds on the mom when they're pregnant, and we're able to diagnose congenital heart defects before the babies are born. We work hand in hand with the OBGYN specialists and specialists called maternal fetal specialists with our OBGYNs with a special training in more complex diseases of pregnancy. And we basically want to diagnose these heart defects before the babies are born so we can have a plan immediately after birth. A lot of babies used to be born and we had to deal with the problem once the baby is born, and sometimes the outcomes were not as good. Now we can plan ahead once we know there's a congenital heart defect to plan where the baby should be delivered, where the baby should be transferred after birth. We can make it easier for the mom, making plans ahead of mom meeting the cardiac surgeon who's going to be taking care of the baby after birth. So all of that, instead of being done when the baby is just born and mom is overwhelmed with the fact that she had a baby with a heart problem, we can diagnose the problem before and make it easier for the delivery of the baby and mom to deal with the problem. Not only we can diagnose problems inside the womb, we can also treat problems, cardiac problems inside the womb. Some babies, for example, can have abnormal heart rhythms, and moms are referred to us, and we can treat the baby through the mom. We can give medications that control or adjust the heart rhythm. We can give the medication to the mom, and we can help the baby through the mom. We can take care of the abnormal heart rhythms. Everybody's wondering how we can look at the baby's heart. It's basically like the normal ultrasound that the mom will get during her pregnancy, but we're only going to concentrate on the heart. There's two ways of doing a fetal echocardiogram. We can do it transabdominal, or we can do it transvaginal. Most of the ultrasounds that we do in our practice and in the hospital are transabdominal. It's like a regular ultrasound. The mom will come to our office, and we will perform the test at the office. Usually it requires to be done by somebody who specializes in, most of our technicians are trained in pediatric cardiology. Some of them have a special interest in fetal echocardiography, but some OB ultrasonographers and some obstetricians will also perform fetal echocardiograms, but it has to be a specially trained sonographer. The sonographers will take the pictures for us, and then we sit down and look at the pictures and discuss what we see at the end of the study with the mom. Like I said before, some obstetricians who specialize in a field called maternal fetal medicine or perinatologists, they will also perform these tests, but most of the times whenever they find an abnormality of the heart, they will usually refer to us because we're the ones that are usually in charge of coordinating the care of the baby once the baby is born. You're probably wondering, who do we perform a fetal echocardiogram on? There are certain indications or risk factors. We're going to go a little bit over it in some of the slides ahead. Like I said, we can do it, the ultrasound can be done transabdominally or transvaginally. Mainly we do transabdominal. Usually the ideal time during the pregnancy to do a fetal echocardiogram is around 18 to 22 weeks. We're able to get very good images. Some moms, if they're smaller in size, we can sometimes see as early as 16 weeks. But most of the moms that we do early screens or early fetal echocardiograms on tend to come back later on during the pregnancy because there are certain heart structures that we're not able to see so early. It's like a regular ultrasound. We apply gel, we use a probe, take pictures. It's not harmful to the baby or to the mom. And it takes the thing about fetal echocardiography, it's very challenging because there's no way you can control movement on a fetus, unlike doing a baby that you can probably pin the baby down and take pictures. On a fetus, you can't control it. Everybody that comes to our office wonders how long the test is going to take. It can take 30 minutes, it can take 45 minutes, it can take an hour. Sometimes we do fetal echocardiograms on twins or triplets or multiples, which will take twice or 3 times as long. But it depends on fetal movement, fetal position, the size of the mom. There's a lot of factors that will affect how long a fetal echocardiogram will take. Endovaginal ultrasounds we rarely do. Sometimes we can do them as early as 8 to 10 weeks. There's not a lot of information that we can take. Basically, most of the information we can take from an ultrasound so early is be able to tell mom, we can see 4 chambers in the heart, or we see a chamber that's missing, because that's going to give the mom some information about what other testing with the obstetrician she's going to be getting to make a decision about what she wants to do with her pregnancy. There are certain indications for a fetal echocardiogram. Not every woman that's pregnant will get a fetal echocardiogram. There are certain indications. There's maternal indications and there's fetal indications. Among the most common maternal indications is any mom who has had or who was born with a heart problem will definitely get a fetal echocardiogram. The incidence of having a baby with heart disease increases. In the normal population, it's around 1%. Somebody who's had heart disease or who's had a prior child, maybe it will increase to like around 2%. So almost all of these moms will be referred to us. Moms who have diabetes will be referred to us. They have a higher chance of having babies with abnormalities in the heart or having, as I explained to the moms, abnormal thickening of the heart walls. So we see them most of the times early during pregnancy in the 18 to 22 week period. And sometimes even if everything looks normal, we'll see them again towards the end of the pregnancy. Even though the baby may have a normal heart at 16, 20-something weeks, they can still develop abnormal thickening of the heart towards the end of the pregnancy, and we want to know who those moms are so we can, again, plan ahead and see those babies when those babies are born. If the mom has been exposed to a teratogen, either medications, they will get a fetal ultrasound. Prostaglandin inhibitors, any mom who has taken anything like Motrin, Advil, any of those medications, they tend to affect the heart and they can cause premature closure of one of the vessels, in simple words to understand, of the heart, and that can be very problematic or dangerous to the fetus. So we see them as well. Some other diseases like lupus, moms who are infected with rubella, moms who have had in vitro fertilization. Nowadays, that's one of the indications to get a fetal echo. And anything that could be inherited that is associated with a heart defect, the mom will be referred to us and have a fetal echocardiogram. I also talked about fetal indications. Not only mom having a problem will make the mom a candidate for a fetal echo, but also things that we see on the baby or sometimes we don't see. Any abnormal feet OB ultrasound, the baby has club feet, the baby is missing a digit, the baby has a brain abnormality. Usually abnormalities come hand in hand, so any baby that has any other abnormality will be referred to us to check the heart and make sure the heart's fine. Any baby with a chromosomal abnormality, the baby has Down syndrome, the baby has trisomy 18, they will be referred to us because we know that those babies have a higher risk of having congenital heart disease. Any baby that has an abnormal heart rhythm, like I explained earlier, they will be referred to us because sometimes they will need treatment through mom to help control the heart rhythm until the baby is born. Anytime they see fluid in the baby, fluid around the heart, fluid around the chest, fluid elsewhere, they send to make sure that there's not a cardiac explanation for the abnormality. Nowadays, they do screening on the first trimester. They check for the thickness of, in simple words, the neck. Any baby that has an abnormality on the thickness of the neck will be referred to us because it's associated with genetic problems and therefore associated with abnormal heart defects. And multiple gestations are referred to us as well, like twins, triplets, et cetera, because sometimes it's being, some babies can have twin-to-twin transfusion, a condition where blood passes from one to the other, and the babies can be sick. The baby that receives the blood can have abnormalities of the heart because of that. Everybody wonders when is, I already told you, but everybody wonders when is the best time to do the fetal echocardiogram. Ideally 18 to 22 weeks because you get good images at the time. Like I said, sometimes it can be possible earlier, but there's a higher chance of having to bring the moms back for more imaging. I'll show you at the end what kind of pictures we're able to obtain. And I'll explain to you like all the little tiny details that you have to look at and be able to see to explain and tell the mom that everything looks okay. So it's very hard to get that amount of information too early in pregnancy. When they come to get the test, unlike most of the OB ultrasounds, the mom does not need a full bladder. It's very important for the mom to come prepared with as much information as she has from her medical history, as well as all the questions that she wants to ask. Once we get the test done, I sit down and discuss the results with mom. And obviously, if they have congenital heart disease or if they have any other problems, it's important that they are able to discuss all the details of their illnesses with the doctor that's discussing the test with them. This is a baby obviously outside, but we're looking at the baby who is inside the mom, which could be laying any possible way that you can imagine. So we have to be very creative in the images we obtain. Like I said, the probe is going to be placed on the mom's abdomen, and we can take pictures from whichever position. We turn the mom on the side, on the other side, on her back. We make her almost like a rotisserie chicken by the end of the exam, because we make her turn so many ways so we can obtain as much imaging as we can, because everybody who comes expects to get all the answers. So we try as hard as we can to be able to obtain all the images that we need to be able to give mom as much information as we have to. We want to make sure, first of all, that the baby has 4 chambers in the heart. As you may know, we all have 4 chambers. We have 2 chambers on the top, 2 chambers on the bottom, and then we have 2 main arteries that come out of the heart. One of the major and most challenging heart defects to take care of are babies who are missing a chamber of the heart. They're born with 3 chambers instead of 4. So it's very important that we're able to see, at least on the first exam, that there are 4 chambers and that there's 2 arteries coming out of the heart, taking blood into the lungs and the body, because some babies can be missing one of the arteries as well. We're able, like you can see there, like I was saying, there's the 2 main pumping chambers on the bottom. The right, as you know, pumps into the lungs. The left, as you know, pumps into the body. In babies, any possible combination of how blood flows through the heart can exist. You can be missing chambers. You can have the right artery coming from the left. You can have the left artery coming from the right. You can have an artery that's missing. You can have the veins that bring blood back into the heart, either from the lungs or the body, draining abnormally. So that's all the information that you want to be able to see that day, so you can explain to mom that everything looks good. We take pictures at different levels in the heart. We can see the chambers. We can see the way the blood comes in, the way the blood comes out. We're able to measure the heart, the size of the heart, the squeezing ability of the heart, and we're able to see if there's fluid or no fluid around the heart, and all those things that we discussed earlier. This is how the real ultrasound image looks like. We're able to see the baby. Imagine that the transducer is up here. We're putting the transducer on the mom's belly, and this is the image we obtain. We usually start our scan by determining how the baby's laying, and after we determine how the baby's laying, the next step is to determine what's on the right and what's on the left, because not only things can be connected the wrong way, things can be laying on the chest the wrong way. The heart can be pointing to the right, the heart can be on the right, the heart can be on the left, but pointing to the right. So those are very important things for us to determine, because if we don't know what's left and right, we can't figure out which chamber is supposed to be on the left, which chamber is supposed to be on the right. So basically our scan will start with that. And then once we do that, determining the position of the baby and where everything is laying, then we move forward to the way things are connected. Like I said earlier, we're not only able to determine the anatomy of the heart when we do an ultrasound like this, we're also able to check the rhythm of the heart. And I know there's another doctor that specializes in rhythm once people are outside the womb, but when the baby's inside the womb, it's not uncommon for us to see irregularities of the heart rhythm. One, because the baby's electrical system is immature. Second of all, because the baby has an opening between the upper chambers of the heart when the baby is inside of mom. And that opening in the heart has a flap that sometimes is long and touches the walls of the heart and irritates the heart and makes the baby prone to having irregularities in the heart rhythm. And when that happens, especially if it produces abnormally fast heart rates, we need to control that abnormally fast heart rate until the baby is born through the mother. So the mom needs to receive medications to control the heart rhythm. And if by the mom receiving the medication, the baby at the same time is receiving the medication, and we can control the abnormal heart rhythm until the baby is born. Once the baby is born, then we take care of the baby, and the baby will remain on the medication for some time. So my special interest, like I said, is fetal cardiology. We do both peds and fetal cardiology, but mainly we try to dedicate ourselves to the fetal field. We take care of babies before they're born, and they become my patients after they're born. We don't do surgeries in our practice. We send them to surgery, and then we receive them when they come back from surgery or from any intervention. So we basically are a non-invasive practice. We take care of babies before they're born, and then throughout their lifetimes until they turn 18. Or if they're born with a congenital heart defect, we keep them until they are adults, and we work in conjunction as well with the adult cardiologists. So I hope I didn't bore you too much. If you have any women that are pregnant that you know in your family, we're happy to see them. Have a good night.